Hello. In this short video, I would like to discuss the idea of incremental pacing. Incremental pacing from atrium and ventricle are the most basic maneuvers during the electrophysiological study. Typically, during EPS, I start incremental pacing from ventricle. Before the further analysis, it's important to be sure that we pace only the ventricle, not both the ventricle and atrium. And the first sign that we pace just the ventricle are the white QRS complexes in the surface ECG. So typically we observe white QRS complexes. The second thing we should check and we should measure is the distance between the stimulus, so the pacing of the right ventricle, and the distance to the signals recorded in catheter and coronary sinus. So if we pace just the ventricle with no atrial capture, this minimal distance between the stimuli, so the pacing of the ventricle and the recorded signals in coronary sinus catheter, should be at least 60 milliseconds. When we assure the proper ventricular pacing, in the next step we should assess the sequence of activation in CS catheter. Eccentric activation means that after the ventricular pacing, when we assure that we've got the white QRS complexes, we observe the earliest activation in the CS catheter and its distal parts. This eccentric activation is the 100% proof of left-sided accessory pathway. So this kind of the activation may happen only in case of the left-sided accessory pathway. Of course, in this case, it's very important to be sure that we've got CS catheter in the proper position, because if we are too shallow, so the CS catheter is moved toward the right ventricle, it's possible that even the distal parts of the catheter are quite close to the septum, and in this case we can have something like paradoxal eccentric activation, which is not true. In case of concentric conduction, it's important to assess the decremental conduction through the AV node during the ventricular pacing. So when we've got the slower ventricular pacing, in this case about the 100 beats per minute, we should assess the SA interval, so the duration between the ventricular pacing and the first activation recorded in the coronary sinus. So we've got SA interval during the slower pacing, and then when we've got the faster ventricular pacing, we should reassess this SA interval. Of course, through the whole incremental pacing, we should have one-to-one conduction. If we lose it, we should assess this SA interval with the last bit with the one-to-one conduction. And in case of the decremental conduction, difference between the first SA interval, so this SA interval with the faster ventricular pacing, and the second SA interval should be higher than 30 milliseconds. However, in some patients, when we don't observe this decremental conduction and we've got the concentric activation in coronary sinus catheter, typically it means that in this patient there is a septal or right-sided accessory pathway. Routinely, after ventricular incremental pacing, I move to atrial incremental pacing. This pacing can be performed from the catheter in high right atrium, so somewhere here, or from the proximal part of the catheter in coronary sinus, so close to the coronary sinus ostium, so close to the AV node. So during this pacing in patient with X-ray pathway, we can observe pre-excited QRS complexes, but typically we observe narrow QRS complexes. And during the atrial incremental pacing, important moment is loss of one-to-one conduction. So we're like in this example, we observe after the pacing from proximal CS, so we are pacing CS 910, and we observe the conduction to the ventricle. With the next bit also we've got the conduction to the ventricle, and then we've got no conduction to the ventricle, and this moment is called Wenckebach point. Assessment of Wenckebach point is important, especially when we ablate in the area of AV node. We should assess it before the ablation and also after the ablation. Incremental atrial pacing can be also proarrhythmic, and in case of the arrhythmia induction, we need to perform the next pacing maneuvers to differentiate between the types of the arrhythmia. Okay, that's all for today. In the next video, I would like to discuss the parahesian pacing maneuver.